What we are, the last presenter finished his presentation and talking about future direction and mentioning about the introduction of the antiviral, the combination of antiviral and birth dose, and birth dose. And we will be presenting, actually what we are presenting here is actually a pilot project using those double combination of antiretroviral and hepatitis birth dose in Congo that we have been doing in Kinshasa. Next slide. So this is mostly a repetition of what we have been hearing from all the morning. Why do we focus on mother-to-child transmission? First of all, because this is a key strategy, a core strategy of the WHO global strategy to limit hepatitis B. We know that the risk of developing a chronic infection depend on the timing of infection acquisition. I think that was presented earlier by the WHO presenter. 80 to 90% of people who get infected perinatally will go on to develop chronic infection. Children that are infected in early childhood, 20 to 30%, and as compared to less than 10% of those who are infected in adolescent or adulthood. Mother-to-child transmission, actually, those who are infected perinatally are a higher risk of developing the liver disease, including hepatocarcinoma. So really the perinatal infection is where the greatest risk of premature death and long-term lower quality of health reside. Next slide. The risk of PMTCT, we have talked about this, and this is relatively to show some of the data or lack of data in the African region. The risk of mother-to-child transmission depend on maternal, on the presence of envelope antigen. We have heard this all the morning, and some of those data have been shown by two presenters this morning. In Asian region, that this data is cited very, very much. In absence of zero of prophylaxis, 70 to 90% of children born to HBE antigen positive mother will be infected. Recent data from sub-Saharan Africa show that this is about 38%. And those with who do not, compare to less than 5% in those who do not have antigen, envelope antigen, who are HBE antigen negative. Timely birth dose do not completely reduce the risk of transmission. And particularly, as the last presenter just mentioned, the previous presenter just mentioned, in African region, it reduced the amount, particularly among those with antigen, with mother, born to mother antigen, HBE antigen positive. It reduced the transmission only, the risk of transmission only slightly, although it completely, or not completely, it almost eliminated the risk of transmission in those which are HBE antigen negative. The timely birth dose vaccination and in combination with the hemoglobin, the HBE immunoglobulin, we don't have data on that in Africa, but in Asia and in North America, we know that it substantially also add to the effectiveness of the intervention. The triple combined intervention, which is a timely birth dose, HBIG, and antiviral, have the most effective, is the most effective intervention in women at high risk of transmission. But again, on that, we don't have any data in sub-Saharan Africa. We don't have any data about the effectiveness of this. This is not really, most of those combined infection, the current data in sub-Saharan Africa from meta-analysis show that those combined interventions do not really matter that much for those who are not at high risk. So for women who are HB antigen negative. Next slide. So the coverage of PMTCT intervention, particularly HBV vaccination, the triple dose, we saw that data from the WHO in 2019 and from Julien as well. Is 85, is 85, and the birth dose is less than 6% in African region. The HBE treatment, really, it's barely available. Even this less than 5%, it's mostly related to those who are HIV positive, dually HIV positive and HBs antigen positive. So there is a really, the next slide. So we have been working in the Democratic Republic of Congo for multiple decades, actually since the peace agreement in 2000 was signed in 2001. UNC and now Einstein have been working in the Democratic Republic of Congo, assisting the government to on various programs, particularly HIV, malaria, and other infectious disease. And in 2013, the DHS 2013-2014, we partnered with the Democratic Republic of Government to get actually data on hepatitis B, as the government was interested in gathering the evidence as in other countries to know about the burden of the hepatitis in general in the country. And our team showed that the prevalence among infant less than 5 was 2.2% using the data from that DHS 2013 to 2014. The hepatitis, the same DHS will show that the hepatitis B, the penta 3 coverage, it was about 61% in those children. So you can see that we even with the penta 3 coverage at 61%, the prevalence is still relatively high. This prevalence have not changed substantially. Those data have not changed substantially, particularly on the coverage up till now. We have not changed that substantially. We also show that this is also very important in the combination, and why we decided to go the way we have gone and trying is that birth facility, health facility birth is very high in the Democratic Republic of Congo. Currently, over 80% of women, actually 85% of women in the Congo would deliver in health facility. And birth dose vaccine coverage are also relatively high, particularly timely birth dose facility coverage in Kinshasa, where this data was covered, is up to 75% if you limit to less than 1 week. And part of this, the reason why it's not really that much higher is what it was described before, is that in some facility, the challenge is in some facility, although they do have the refrigerator system there to do it, which is usually the API refrigerator system, is locked during the weekend, and children who are born on Friday evening, for example, have to wait till Monday to be vaccinated. And that limit the timely birth dose substantially. And at this point, I will pass it to Peyton to actually present you the result from the study we have conducted, the pilot study we conducted.
Thank you, Marcel, and thank you to the Coalition for inviting us to speak today. So I will transition into the AVERT HBV study, which stands for Arresting Vertical Transmission of Hep B in the DRC. So the goal of this pilot project was to demonstrate the feasibility of screening pregnant women for surface antigen, as well as treating those who are at high risk of mother-to-child transmission, defined as either a viral load over 200,000 and or e-antigen positivity, as well as provision of a birth dose vaccine for all exposed infants. And this was really possible because of integration within the HIV PMTCT framework thanks to Marcel's ongoing R01 study, as well as within the EPI framework, thanks to collaborators. And the setting for this study was 2 high-volume maternity centers in Kinshasa province. In terms of study procedures, we first approached women for verbal consent for point-of-care surface antigen testing, and then those who were positive were approached for enrollment in the study. We then determined the risk status of these mothers by further laboratory testing and provided antivirals for women at high risk from 28 to 32 weeks gestation through 12 weeks postpartum. We then provided a birth dose vaccine, which was available for all infants, ideally within 24 hours. This is a graphical depiction of the study laboratory procedures, in which you'll note that the high-risk women were followed more frequently to assess their liver function testing. And we followed all infants and mothers through 24 weeks postpartum, ideally, at which time we tested the infants for surface antigen. I'm excited to share with you our results, which we will be submitting for publication this week. We assessed over 4,000 women for surface antigen testing, of whom 109 were positive, and 91 of those were eligible for enrollment in the study. This represented an overall seropositivity of 2.7% among these pregnant women. Looking more closely at the high-risk women, we found 10 women who were high risk, which represents 11% of our study population. 9 of these women were E antigen positive, and 5 of the 10 had a high viral load. 9 of the women accepted tenofovir prophylaxis, and 5 of those 9 achieved viral suppression at delivery. Now, getting into the meat of it that you all will be most interested in today, this represents our birth dose vaccination results. So of 88 infants born in this study, 68% of them received a birth dose vaccine, and 77% of those were timely birth dose vaccine. So you can see in this figure the reasons for either not receiving a birth dose, which included the mother withdrawing or being lost to follow-up, and reasons for untimely birth dose. As Marcel and others have mentioned, 2 babies were born on the weekend, and so the staff didn't have access to the EPI freezers or fridges to administer those vaccines. And then many of the women were born at facilities that were not one of our 2 study facilities, and so we weren't able to get the vaccine into those babies within 24 hours. However, of the infants born at our study facilities, 73% of those received a timely birth dose vaccine. And so while this demonstrates a targeted approach to birth dose vaccination, we believe that universal birth dose vaccination is possible in Kinshasa if the birth dose is available at all of these different facilities. And finally, I just wanted to show that the infant vaccination, which you'll see in the middle of this figure, was highly acceptable to mothers. Greater than 80% reported it being very acceptable. In conclusion, we showed that it is feasible to add Hep B testing and PMTCT measures to the existing HIV and EPI infrastructure in Kinshasa. The overall prevalence among pregnant women was 2.7%, with 11% being high risk, and these figures are in line with other studies in the region. And using this approach, we had 0 cases of vertical transmission in these infants. We did uncover challenges in implementing a timely birth dose, namely infants being born at facilities that were not our study facilities, as well as ensuring adherence to follow-up visits. So we know that in this context, there are large rates of loss to follow-up, and Marcel has seen this in other studies that he has conducted as well. And so these are challenges that we will take into consideration as we plan future studies. I would like to acknowledge especially our Congolese colleagues who made this work possible, from KSPH, our study team, the staff at the maternity centers, the study participants, the Ministry of Health, AIDS Control Program, National Transfusion Lab, and of course our partners at PEV, EPI. Thank you very much, and I will stop sharing.
Thank you very much, both of you, Marcel, Peyton.